course. Okay, this will be held completely via Zoom online, and this is done in partnership with Unilab for continuing medical education. So before we start our program today, let's give respect to our national flag. So the Philippine national anthem.
Mga kababayan, ang pambansang awit ng Pilipinas.
Let's all observe a moment of silence for the invocation. So good afternoon, everyone. I'm Dr. Billy Jensu. I'll be the review course coordinator for today. And it's my honor and pleasure to introduce to you the master ceremonies for today. She's a practicing general cancer laparoscopic surgeon, liver and transplant surgeon. And these are her credentials. She finished her general surgery residency at Manila Doctors Hospital. Also, she was a chief resident on her last year. She finished her minimal invasive surgery fellowship at Asian Hospital and Medical Center in January 2016 to February 2017. It's also a clinical fellowship program, Advanced MIS, training in IRCAD Asian Institute of Telesurgery in Lukang, Taiwan, and also did her clinical fellowship program in liver surgery and transplant in China Medical University Hospital, Taichung, Taiwan. And also our moderator for today, actually it is her birthday today. Okay, so we'd like to greet her a very, very happy birthday. Let's all join sing a song for Dr. Gretel. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday. Happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday. Happy birthday to you. Happy birthday, Gretel. So let's welcome our master ceremonies, Gretel Puzon. Hi, Gretel.
Hi, sir. Thank you po. Thank you, Sir Billy. Sikreto lang dapat yun, sir eh. Binuking nyo naman po ako. Ang dami ko na tuloy papakainin. Oh, nako. Anyway, today is the birthday of one of our committee members as well. So she's my immediate senior when I was a resident, Dr. Avril David. Ma'am Avi, she's not here pero damay ko na kayo. Happy birthday, ma'am.
Happy birthday,
Okay.
Avril.
So we'll start, sir.
Okay.
Okay, thank you, sir. So good afternoon. I will be your moderator for the next 3 hours. So this will now be the third day. We are now halfway done with the review series. As you know, we have invited lecturers who are all experts in their respective fields, and we are very, very lucky to have them share their knowledge through this review course. We will be providing you a PDF copy of all the PowerPoint slides. So we just need you to stay awake, listen, and try to grasp the important concepts as much as you can. And at the end of each lecture, there will be a series of practice questions. Please participate and answer them. If there are certain topics or questions that are confusing, just let us know so we can ask our lecturers so that they can explain these further if we still have time. So we will be covering 3 topics today. There you go. So from 2 to 5. So to start off, let me introduce our first lecturer. She finished her general surgery training in Philippine General Hospital, where she served as the deputy chief resident during her senior year. She underwent fellowship training on trauma and critical care in the same institution and is currently the board secretary of the Philippine Society for the Surgery of Trauma, course director of the Best Emergency Skills in Trauma of PCS, head of the surgical ICU of Jose Reyes Memorial Medical Hospital, program coordinator of the Critical Care and Trauma Surgery Fellowship Program Consortium, and section chief of Trauma and Critical Care in Rizal Medical Center and Batangas Medical Center, just to name a few. So to give us a lecture on trauma surgery and critical care, we have Dr. Irene Madrid.
Thank you very much, Gretel. And again, happy birthday.
Salamat po, ma'am.
So thank you for your dedication despite your birthday. You're still here to help us. So thank you very much. Allow me to just share my slides. Okay, so this is a bit of an unholy hour kasi after lunch, and I'm sure you guys are a bit sleepy after eating a heavy meal. So please get your coffee because we are starting with, I think, the most unpopular topic for the entire series. So we don't want critical care kasi toxic, but admittedly we have to learn about it because it's part of our curriculum. Actually, it's part of the PSGS curriculum. So let's start with this so we can get this over and done with. So hindi naman, we will not go heavily into a 2-year fellowship in critical care, but I will just show you the topics that are in your curriculum, so you will know which topics to review. Okay, so for your exam in RIT and series, these are the topics that are must know. So first is yung shock, and then followed by nutrition, and then your fluids and electrolytes. I think you have another session for that, so we will not go into that in detail. You have your acid base disturbances, your endocrine, and your metabolic response. So if you look at the breakdown, it's usually shock. So for exam purposes, you have to be familiar. Usually we ask about septic shock and hypovolemic shock because these are the types of shock that we usually encounter in our surgical patients. Usually when I make the exam, I try to make it depending on the year level. Now for the juniors, usually it's just direct recall, but for the seniors cases, but actually the cases are easier to answer because sometimes there are clues in the questions that can help you arrive at the right answer. So these are the topics. Now we will not go into details sa ibang like inotropes and everything because wala naman siya sa curriculum. So again, the must know topics are or include shock, which includes your hypovolemic and your septic shock, especially septic shock. So you have to be familiar already with the sepsis guidelines. And in first hour bundle, what to do within the 6 hours, including your source control. Because yan talaga yung minamanage natin mostly na pang GS. And then of course, your nutrition. Okay, so for example, for shock, you have a 65-year-old male admitted for PGO. So lahat naman tayo had our a case of PGO at one point in our training. So this is a 65-year-old male admitted for PGO with the following weight and hemoglobin. So usually when you're given with the hemoglobin, ibig sabihin, it will tell you na probably it will signify your oxygen carrying capacity kasi yun naman yung importance of transfusing, di ba, even for trauma. Enough ba yung hemoglobin to transmit your oxygen throughout the body and therefore not go into shock. For critical care, the guidelines suggest that medyo conservative in transfusion with okay na tayo with the 7 to 9 gram per DL na hemoglobin as long as walang active bleeding. That's for critical care. So we're not very aggressive in transfusion. Why? Because in your TRIC guidelines, yung conservative transfusion has better outcome than the liberal transfusion where you would want a 1 or a 10 gram per DL na hemoglobin. So for this case, 12. So sobra-sobra na. So probably the problem is not the oxygen carrying capacity. But mababa yung O2 sats mo. So there's supply of oxygen, but what's wrong? Bakit ka nagdidesat? And the patient is clinically dehydrated. So obviously, we are probably dealing with a septic shock here. Ang BP mo is 95/60. So if you remember your sepsis guidelines, ang target map natin is 65. So which of the following will increase oxygen delivery to the tissues? So at this point, ito yung choices mo: antibiotics, fluid challenge, oxygen therapy, and transfusion. So pwede na natin alisin yung transfusion, right? Kasi okay yung ating hemoglobin. So you're left with your oxygen therapy and your fluid challenges. So alam naman natin na more than 100 or more than 10 grams per DL yung oxygen. Ang problem is if dehydrated yung patient. So for us to reach the tissues, to have gas exchange in the peripheral organs, then mas maganda na ma-hydrate natin yung patient. So that's very important for septic shock, hydration. So the best answer, of course, you can give oxygen therapy, but the best answer for this case, especially since leading yung question that your patient is clinically dehydrated, is your fluid challenge. So for septic shock, from the recent guidelines, what's recommended is 30 cc per kilo na bolus yun ang ibibigay mo at the first onset. So the patient gets to you. For the first hour bundle, you want to give your antibiotics already. You want to get your blood cultures before you give your antibiotics. You want to give your fluids at 30 cc per kilo, and followed by your 6-hour bundle, which already includes your source control. So whether it be a necrotizing fasciitis or ruptured appendicitis, the bundles remain the same. No? Yung source control lang yung nag-iiba. Therefore, yun yung kailangan natin i-remember sa septic shock kasi yun lang din yung magandang evidence. So that's how we usually ask questions for critical care. So in one question, marami na tayong medyo na-discuss with regard to septic shock or sepsis guidelines. Yung hypovolemic shock, dadaanan natin sa trauma. Kasi mas maraming questions usually for trauma than your critical care. So next, nutrition naman. Very important, no? Sa dinami-daming nutrition lectures that we go to. Ang dami-daming conferences, ang dami-daming workshops. We all have these products, TPN, Elemental, all these milk formulas, no? But the reality is wala pa ring perfect or the best recipe for nutritional upbuilding or for nutritional formula, no, for our patients. Wala pang magic number, wala pang magic bullet. So hanggang ngayon, we're still trying to look into all the data, look into all the guidelines. Wala talagang perfect formula. So it's useless to memorize stuff on nutrition. I just want you to remember that when we make exam for nutrition, ang importante alam nyo when to start and how to feed your patient. So again, ang level 1 evidence for nutrition is that we feed them early. But we don't feed them agad-agad with a full caloric requirement kasi we don't want to deal with refeeding syndrome, especially when our patients come in nakakektic, may cancer, we had difficulty upbuilding the patient, or may gastric outlet obstruction. So for questions, sometimes we put kung which statement is true. Basta yung pinaka-importante, early feeding, but not too much. So yung principle is start low, go slow. Basta in a week, ma-reach mo yung incremental yung feeding, basta ma-reach mo yung total caloric requirement within a week. And enteral talaga yung first choice. So for all the nutritional biochemical markers that we have in our hospitals, what that actually predicts prognosis, kasi yun yung gusto natin prognosis for our patients, especially since we're talking about critically ill patients, is your pre-albumin. So not albumin, not transferrin, not lactoferrin. So pre-albumin, it has something to do with the synthesis of albumin. Hindi na natin siya masyadong i-discuss kasi hindi na masyadong important to you guys. Okay, next is fluid and electrolytes. So I'm sure you will have I think you will have a separate lecture for this. It's kind of important because nasa top 3 siya. So for critical care, it's shock, nutrition, fluids, and electrolytes. Those are the top 3 topics. So when we're given the exam blueprint to make your exam for either CERES or RITE, we follow the blueprint. And yun yung top 3 topics that you need to make questions on sa critical care para lang may guide kayo kung ano yung topics that you need to focus on. So let's look at this question, okay? So you have a post-nephrectomy patient admitted at your surgical ICU. You have the following lab results, no? Your albumin is 3.9, your potassium is 3.1, magnesium is 2, your calcium is 7.8, your phosphorus is 3.2. You correct the serum potassium with 3 cycles of IV, pero instead of your potassium increasing, mas lalo siyang bumababa. So tapos IV correction ka na. Usually kasi when we're dealing with post-op patients, although hindi natin masyadong ayaw natin ng masyadong aggressive na correction, no, but if we want to correct, there's the regular and the fast correction. So I guess hindi to fast correction kasi 3 cycles siya. So what's the magic electrolyte that we need to give if we are having difficulty with our correction ng potassium? So I rarely give exam questions na i-memorize niyo yung laman ng fluids or i-memorize niyo yung laman ng calcium gluconate or how to make your corrections, because you can easily Google that. When I make an exam, mas gusto ko yung maintindihan niyo yung concepts. Kasi madali naman i-Google yung mga formulas and whatnots, but the concepts, once you understand them, hindi sila kailangan i-memorize. So for this case, actually, when you're having a hard time correcting your potassium, the next, especially pag naka 3 cycles na kayo, the next step will be to give your magnesium. And it has something to do with the intra and extracellular ions and cations and your electrolytes and your physiology. So hindi na tayo masyadong mag-dwell in physiology kasi I have another lecture about the shortcuts of everything, but bibigay na lang natin as PDF for you guys to study. Next, acid-base. So we give, I'm sure we've handled a lot of trauma cases already, especially the seniors. Sanay na tayo to do massive transfusion in our patients. So for this case, we have maraming tinransfuse, no? Tapos nagkaroon ng excessive citrate. So usually when we do our first round of MTP, we give a lot, there's a lot of citrate as buffers in those blood products. Although they can be metabolized by the liver eventually, but if we're transfusing a lot of blood, hindi agad-agad ma-metabolize ng liver yung citrate. And what happens now? So medyo tricky kasi to because when you put citrate, di ba, you remember your citric acid cycle. So again, hindi ko na kayo toxikin kasi mga surgeons ayaw nilang matoxic kasi hindi daw sila nag-IM. But something happens in your citric cycle inside the cell, no? And eventually, you will have decompensated metabolic alkalosis. Yan. Yan yung most obvious, no, aside from the compensation, which is respiratory acidosis to compensate for your metabolic alkalosis. But the primary acid-base disturbance for massive transfusion is a metabolic alkalosis, which you have to deal with kasi initially your patient will be acidotic because of all that blood loss, right? But when you start doing your massive transfusion, then this happens. So these are just examples of the questions that are given in your previous exams. The next is endocrine response. So ito yung mahirap ipukpok kasi too many hormones. Actually, if you think about it, no, toxic talaga yung surgery because there's too much going on after the surgery. So we cannot say na ignorance is bliss kung hindi mo alam, okay naman yung pasyente, post-AP, okay naman siya, walang complications na ho. It doesn't mean walang nangyari at the molecular level. That's why medyo mahirap talaga yung surgery if you actually want to understand. And these are all in your chapter 2 of Schwartz. So I'll probably email a copy. I made a lecture on the chapter 2 kasi that's where I usually get your questions for the endocrine and metabolic response to surgery. Sobrang high-tech na actually ng Schwartz. No? They have all these molecules, heat shock proteins, DNA, Siglex, all these receptors are already discussed there. But what I usually want when I make the exam is something that has clinical significance. What happens to your patient that you can clinically appreciate, and therefore we know what to do with them already. So during surgery, which hormones are decreased. So if you look at your chapter 2 of Schwartz, there's a table. Mahilig ako kumuha ng mga exam from the table. So if you don't have a lot of time reading because marami kayong trabaho sa hospital, then try to look at the, if you want to study for critical care, aside from reading or familiarizing yourself with the sepsis guidelines, try looking into your chapter 2 of Schwartz and look at the tables kasi dun ako usually kumukuha ng pang-exam. And then finally, metabolic response. So this is one of my favorite questions to ask, no, for patients in the ICU kasi we have a lot of patients na graduate na sa SICU but sa ward parang hindi pa rin sila, no, hindi pa rin sila okay. And then after a few days, we discharge them, tapos babalik sila after a week and parang hindi sila naka-recover. So the syndrome characterized by your prolonged ICU stay, complication, post-discharge, and failure to regain pre-injury status. So the keyword is failure to regain pre-injury status. And I also got this from your chapter 2 of Schwartz. So the answer is PICS. No? So in your book, nandun yung graph of what the CARS mean, what your SEERS mean, or what your MARS mean. So marami silang ganun. Marami silang syndromes in the ICU. There's this mixed antagonistic response. There's overwhelming inflammatory, pro-inflammatory response. You get your SEERS. And then there's this excessive naman na response to SEERS or the compensation of your anti-inflammatory response to balance SEERS out. So that's your CARS. So minsan sa name pa lang ng syndrome, you get an idea of what they are. So again, for critical care, I'll just go back to the slide. At least hindi kayo masyadong ma-intimidate and you will have an idea kung anong lalabas sa exam. Again, this is the breakdown. No? This is usually the test blueprint that we make for critical care to make it fair to everyone. Kasi hindi naman lahat interested to go into critical care. Basta ito kasi yung nasa ano ninyo, nasa what you call this PSGS curriculum, the must-know topics for critical care. Again, shock, nutrition, fluids and electrolytes, acid-base, endocrine response, and metabolic response. For the last two, you just need to browse your chapter 2 of your Schwartz. But I will also give a PowerPoint or a PDF for that, which you can browse later. So now let's go into trauma. And I'll just stop share and get my other PowerPoint. So let's move into your trauma review already. Mas marami kasing questions for trauma. Yan, kasi ang dami-daming protocols that we need to be familiar with. If you have attended the best series of lectures, then you won't have a hard time answering your exam for trauma kasi we try to stick with the best guidelines. So I summarized the guidelines here so you can run through them one by one. So again, when we talk about trauma, a major chunk of it is your ATLS or your primary survey. So even with your oral exam, kasi even if you're not a surgeon or if you don't you're not really comfortable with doing trauma surgeries, very important that you know how to do your initial management, because that's the best evidence out there. That's expected, no, as the best um, series of management strategies that we can use para magkaroon ng fighting chance yung patients natin at the ER. So again, airway with C-spine protection, your breathing and ventilation, your circulation and control of hemorrhage, your disability, and your exposure. So let's start with A. If your patient is hypotensive and you will need to operate on the patient, kunwari gunshot and stab at the abdomen, you will not be faulted if you will intubate this patient at the ER kasi hypotensive na siya. That's already an indication to intubate your patient. If not, if argue niya na, ma'am, the upper airway is clear, I'll just give full O2 support, then that's also an acceptable answer. Very important that you protect your C-spine. We had a case no na hindi na detect na may C-spine problem, and when the resident started to intubate, nag-arrest yung patient. Next is breathing and ventilation. So for this case, if you attended the Southern Tagalog chapter na Joint Trauma Conference, the big three no, that you need to rule out during your breathing and ventilation is your tension pneumothorax, your cardiac tamponade, and your massive hemothorax. So yun lang yung tatlo, kasi what you want to rule out here in the breathing and ventilation are the top three life-threatening conditions for injuries to the chest. How do we go about differentiating each one? Titingnan natin later on. For circulation and control of hemorrhage, it's not enough to put in your IV lines. You have to go through all the areas kung mag-bleed will cause hypotension, and that includes your chest, your abdomen, and your retroperitoneum, your pelvis, and the long bones. So if you notice, your adjuncts at the end of your primary survey are geared towards looking for that cause of bleeding or hypotension. No? Your pelvic x-ray, your chest x-ray, your FAST, they're all geared towards looking into those compartments that can bleed and cause hypotension. For the recent evidence, no, for the IV fluid that you give, the latest ATLS guidelines says 1 liter. If you have a permissive hypotension option in the exam and the injury is penetrating, then the best answer is permissive hypotension. But if for blunt or multiply injured, or for patients with traumatic brain injury, then we stick with 1 liter as per ATLS guidelines, because we want to overcome that cerebral perfusion pressure, no, para magkaroon ng circulation in the brain. Again, hindi 2 liters, 1 liter na lang. If your patient is less than 3 hours post-injury and exsanguinating, then that's the time we give tranexamic acid. If you're dealing with cardiac tamponade, na your problem is breathing, your problem is an obstructive type of shock, or your tension pneumothorax, wala namang bleeding component, so you don't need to give your tranexamic acid. Beyond 3 hours, walang benefit, and it will tend to harm, no, based on the forest plots that they published. So please shy away from giving tranexamic acid beyond 3 hours. Hindi nga lang siya no effect, it tends towards harm. And this is probably because of the thromboembolic complications brought about by too much tranexamic acid, especially if you don't need it. Next is your disability. Disability, tatlo lang yung kailangan ninyo. Your GCS, your lateralizing signs, and your pupils. We're not still using the GCSP in ATLS kasi hindi pa siya ganun ka-validated. For exposure, this is the time you log roll your patient, you look at the back, you check the spine for any deformities, you do your rectal exam, and then you prevent your patients from getting hypothermic. Okay, so for example, no, you have a 26-year-old female. She's 8 months pregnant with multiple stab wounds in the chest and abdomen and neck. So look at the BP. Your patient is already hypotensive, tachycardic, tachypneic. So her stab wounds, meron ka sa fourth ICS, parasternal border. So Meron ka din sa laceration of the left and right subcostal area, large laceration, and the zone 2 left neck area with profuse bleeding. So what will you do next? So syempre ang daming nagbe-bleed na your patient is hypotensive. So ang instinct natin is tumakbo na sa OR and bring this patient to the OR immediately. Always remember your primary survey in whatever patient you manage, whether it be elderly, pregnant, or pediatric. So you assess the airway, especially since there's bleeding, na baka na-compromise yung airway mo. Large hematomas have a way of compromising the airway. And we don't want to do surgical airway for patients with large hematomas kasi ma-release natin yun. So try to secure the airway first. You can have someone to pack the bleeding, someone to assess the breath sounds, or someone to insert IV lines. But the answer is always go back to your primary survey and start with your airway. Again, ang goal natin is to assess the most immediate or the immediate threat to life. And we always begin with the airway. Yeah, so let's skip this one pang oral exam yan. Okay, so let's go to your penetrating and blunt chest injury. So the good thing about this is over 85% of injuries in the chest can be managed with chest tube alone. One of the life-threatening injuries can be identified sa primary survey. Kaya yung big three, always remember your tension, your cardiac tamponade, and your massive hemothorax. So let's run through them really, really fast so we won't extend sa time natin na allotted. So ito yung three conditions. Let's start with pneumotension. So because of the pressure and the injury in the lung, your lung is collapsed. So kahit saan ka tutusok, wala kang tatamaan if you want to be piloso potasio. But initially, the location that we know of that's recommended is the second ICS, mid-clavicular line of where the injury is. Now, they did a lot of studies in abroad, and they found out that since most of their patients are Caucasian, they have their barrel-chested or very thick pectoralis major muscles, hindi nagpa-penetrate yung second ICS. That's why they transferred it to the fifth ICS, mid-axillary line. Yan kasi yung thinnest area, no? your auscultatory window. That's also where you put your chest tube kasi manipis yung muscles. So if you put your needle there, then sure ball, papasok yun. But for our purposes, the first site that we still recommend is the second ICS kasi medyo payat naman yung mga pasyente natin unless we specify in the exam na your patient is a bodybuilder with very thick pectoralis major muscles, then parang nililid na kayo na probably yung second ICS needling won't work. Pwede bang diretso sa chest tube yung answer, ma'am? No. Because tension can kill in a matter of seconds. You need to decompress that lung to buy you time so that you can get your materials for your chest tube. Therefore, needling is the initial management. The definitive management is a chest tube. For tension pneumothorax, again, it's an obstructive type of shock. Dahil sa pressure here in the lung, hindi makaakyat yung blood from the IVC. That's why you get hypotension because of decreased cardiac output. Next is your massive hemothorax. So what's the difference between your tension and your massive is that in your massive, there's a blood loss component. So you will not see your distended neck veins in your massive hemothorax kasi meron ka ng blood loss component. For our definition, massive is 1 liter. So whether hindi kasi sa books kasi ninyo sa Mattox and Schwartz, it's 1.5, but that's because of it's a Caucasian measurement. So for the exam, we always set our standard at 1 liter. So 1 liter yung lumabas, diretso thoracotomy siya. The temporizing management, kung needling for tension, for massive, it's chest tube. Why? Because it will expand the lung, have some semblance of IVC return, which will increase your cardiac output. But you need to bring your patient up to the OR for a formal thoracotomy to control that bleeding. Your expanded lung can also tamponade, especially if your bleeding is just in the intercostals. Next is your cardiac tamponade. No? So Perpetual, they presented a case of cardiac tamponade. Ang kalaban kasi natin with these top 3 conditions is time. Kumbaga, umabot kasi siya sa hospital ninyo, so nasa kamay niyo na kung namatay siya or hindi. But kaya kailangan mabilis talaga tayo to diagnose. And all these entities are clinical. You don't need any radiographic evidence. They're all clinical. So what makes it different from the first two? Syempre maganda yung breath sounds mo kasi wala ka namang injury sa lungs. Pangalawa, of course, your stab wound has to be in the periphery or near your or at the cardiac box. Kasi kung malayo naman dun yung injury, parang hindi man masyado natin iisipin. So again, what makes it different from the breath sounds problem or kasi lahat sila hypotensive eh. So distinct yung heart sound, breath sounds mo for tamponade, but you may find muffled heart sounds or neck vein distension, but not at all the time. No, only 20 to 30% of cases present with your Beck triad. So what's the temporizing maneuver? It's your pericardiocentesis. Ideally, it should be ultrasound guided, but if you're sure that it's a cardiac tamponade and you don't have it, then you can probably perform it using your largest, probably your gauge 18 needle. Kung wala kayong spinal needle, dalawang gives yung ma-feel nyo. You point 45 degrees towards the right shoulder. Your pericardiocentesis is not a diagnostic tool. It's a therapeutic modality to tide over and you can bring your patient up to the OR. So, pwede bang hindi i-perform, ma'am? Well, kung kaya nyo mag-ED thoracotomy, then great. Pero if you don't usually practice ED thoracotomy, wala kayong finucchiato or aortic cross clamp at the ER, do your pericardiocentesis, keep the needle there, para pag nag-reaccumulate, you can aspirate blood again. The positive sign for everything is improvement in your blood pressure, not the gush of air. That's usually what I hear the residents say when we talk about tension pneumothorax. It's not the gush of air. Lahat ng pneumothorax may gush of air. It's actually the improvement of your blood pressure. The same goes true for cardiac tamponade. It's not the blood that you aspirate. Malay nyo nasa ventricle pala kayo nakatuso kaya blood yung na-aspirate nyo. It has to be the improvement of your BP. So you have to have someone to check your blood pressure when you start doing these procedures. So again, this is a restrictive type of shock like your tension. So hindi siya blood loss ang kalaban mo. Usually these are mga 1 cm injuries to the ventricle. Again, this slide just shows you the summary now of how to differentiate the big 3. So don't you worry, this will be given to you after all your lectures. So you can browse them again. Ang importante, maintindihan ninyo yung concepts. So now let's go to blunt cardiac. This is rarely seen, no? But what will point having blunt cardiac injury is usually your seatbelt signs, abrasion to the chest, of course, a blunt injury, unexplained tachycardia. And you want to work them up, and we usually just bring these patients to the ICU for monitoring. We had a case na kailangan i-cabbage, but very rare. So again, blunt cardiac is not usually surgical. Yun. Speaking of penetrating injuries pala, before we move on, no, the absolute indications, no, for removing your bullet slugs. Pag nasa abdomen, a relative indication for when to look for that slug and remove it is if may nahit na colon or bowel. Kasi sobrang taas ng chance that you will get fasciitis So try to look for that bullet. Kung hindi naman sa abdomen, no, the absolute indications that you need to remove the bullet is if nasa loob ng vessel, if nasa loob ng heart, and if nasa intra-articular area. Kasi sa joint, the synovial fluid, the acid there will cause dissolution of your lead, and your patient can get lead poisoning. So those are the absolute contraindications na kailangan mong tanggalin yung bullet. Otherwise, it can stay there. The natural course is extrude ng body all the foreign material in your body. So next is we go to penetrating cardiac injury or suspected cardiac injury. Again, dapat nasa cardiac box yung injury. If your patient is normotensive, then you can just request for an X-ray to the echo or a pericardial ultrasound. And pag negative, you just admit and treat other injuries. Pag positive, this is where the confusion comes in, because you have to identify if it's mild, minimal, moderate, and massive. Usually the radiologists who do the reading, they have a cutoff, no, like 5 millimeters and the like, to say if it's moderate or massive, or they can just indicate. Pag moderate and massive, we do thoracotomy. Pag minimal, then that's the time we do subxiphoid window. Bakit subxiphoid window? We won't see this protocol in the US. We do subxiphoid window because we have local data that most of minimal pericardial fluid are because of TB, not because of the trauma pag minimal lang. So if minimal, we just do subxiphoid window, we do pericardial biopsy pag hindi blood yung lumabas sa window. Otherwise, if it's moderate to massive, then we proceed with thoracotomy. For hypotensive patients, we do thoracotomy outright, but we temporize with pericardiocentesis if because our consideration is tamponade. Now, the question is, paano kung hypotensive, the patient came in 70 pulp, nagload yung first year mo ng 500cc, the BP went up to 90/60, less tachycardic. What will we do? Will we treat it as normotensive? Can we safely work this patient up? Or we can do pericardiocentesis or a subxiphoid window. So maraming options. But the most correct answer, is to do your thoracotomy. Itong blue line. Again, ang ano kasi sa trauma, that one episode of hypotension is always considered significant, and we have to always err on the side of patient safety. We cannot discount yung hypotension eh. So meron na talaga kayong ticket, no? Meron na kayong golden ticket to open the patient up. Even if yung hypotension initially nag-improve, even if your patient is a responder, the fact na may one episode of hypotension, do not go to the ultrasound, do not go to the X-ray. Kahit normotensive na siya, bring the patient up to the OR for thoracotomy, and that's the protocol that is endorsed by PCS. So yan yung sinusundan natin for now. So always remember, no, pag yung stab is in the thoracoabdominal area, always look at the two compartments, because you might end up with sana nakikita niyo si X-ray. So the bowel might go up to the chest wall. So, or the chest compartment. So you have your acute diaphragmatic herniation, and when you see this and you have bowel perforation, then you are expected to do your transdiaphragmatic pleural lavage. Hindi po pwede na lalagyan lang natin siya ng NGT and we flush, no? When you do your TDPL, especially for hollow viscous injury and a thoracoabdominal crossover with injury to the diaphragm, you have to extend your diaphragm radially to the point na magkasya yung kamay ninyo hanggang apex of the lung, and you will be able to clean it out. If you have to look at the history kasi before, talagang outright thoracotomy and XLAP pag may ganitong cases. But the morbidity of having an XLAP and thoracotomy together is very high kasi hindi biro yung no XLAP ka na thoracotomy ka pa. That's why the TDPL is a compromise, but you have to do it correctly. So a lot of the seniors fail in the oral exam because they don't know how to do the TDPL. Now we'll go to the penetrating abdominal injuries. You all know your indications for laparotomy, no? Yung peritoneum, impaled foreign body, blood in all the orifices, hemodynamic instability, fast positive, and your... Basta ang goal dyan, ang key dyan is there's proven penetration. Whether you do a screening laparoscopy to check kung pumasok yung implement or a fast and you see that it's positive, then that's already our ticket to open the patient up. What about for equivocal abdomen? So this medyo equivocal abdomen yung palagi binibigay sa oral exam because it's more difficult to manage. Nakakalito. So these are what you can use for your equivocal abdomen. No? Serial PE. Dapat isa lang yung gagawa and balikan yung patient every 15 to 30 minutes or so for a period of an hour. DPL. Even if you don't perform DPL in your institutions, the indication for this is to check if there's bleeding in the abdomen, and usually if it's a different positive DPL for penetrating in blood. Just know the details later on. Local wound explore, the only indication for us to do this is a single stab wound to the lower quadrant na hindi ice pick or barbecue stick yung ginamit. Otherwise, it would be too small to do a local wound exploration pag ganun. And the trajectory is quite difficult to predict. For, CT scan, medyo OA na siya, but in US kasi lahat sini-CT scan, kahit stab yan or ano, sini-CT scan nila. And of course, laparoscopy, which is gaining acceptability and popularity already because you can have a direct visualization kung pumasok yung implement or not. Again, even if sa tingin mo, benign yung laparoscopy mo, or there's just minimal hemoperitoneum on scans, the fact na meron, you have to open the patient up. Hindi pwedeng nag-diagnostic lab ka lang. Ang protocol natin is once there's proven penetration, the next step would be to open the patient up. Yes, there's the risk of having a non-therapeutic laparotomy, but the benefits outweigh the risk. So we still open the patient up as soon as we determine that there's proven penetration. Now, let's go to the different abdominal organs kasi iba-iba yung management nila. Let's start with the colon first. So you have to be very familiar. I think the next topic to this is colorectal. No? So let's just go through the colon guidelines briefly. So you just classify if it's a destructive or non-destructive colonic injury. Our goal is to most of the time, or our goal for trauma is to anastomose or repair. The only time na hindi natin siya anastomose or repair and we do colostomy if pag sobra yung peritonitis. What do we mean by peritonitis in trauma? Kasi iba-iba kasi yung definition ng peritonitis. Pag hindi mo natahi, that's how we view peritonitis in trauma. Medyo matagal na yung injury, maga na yung bituka, pag tinahi mo nagka-cut through, then that's the time we exteriorize. If there's no peritonitis or a significant medical disease or a 3-organ involvement, no, for recent guidelines, dinagdagan pa nilang more than 6 units of transfusion. If you have this, then that's the time that you consider probably exteriorizing. But for all intents and purposes, we rarely or we discourage you guys to do colostomies in trauma. Pwede nyo namang tingnan yung evidence why hindi na natin siya i-nitpick, but we rarely do colostomies. Even for damage control, we just tie them off, not exteriorize them. Mas maraming complications. So again, even if for destructive or non-destructive, either you repair or you resect anastomose, basta ipagdugtong nyo. The only time we exteriorize ay sobrang maga, sobrang peritonitis, hindi natin matahi yung bituka, or your patient has significant medical disease, or three organ involvement. Ibig sabihin nito, may from the esophagus down to the rectum, that's just considered one organ for trauma. So dapat may liver, may spleen, may pancreas, may duodenum, may bowel. And that's the time you probably think of exteriorizing. For the spleen, let me reiterate this. We don't do splenorophies in trauma. If you've done a lot of surgeries for shattered spleen or for grade 4 splenic injuries or for those types of things, gunshot, the more you suture, the more they bleed. So, and if you put a lot of pledgets or foreign bodies, they're very prone to abscesses. So you pack the spleen. If it's still bleeding after you pack, remove it. If it's not bleeding, leave it alone. We rarely do partial splenectomies or put in your mesh to prevent from bleeding. So yun lang. Why? Because the evidence for or the spleen, if it rebleeds, the mortality is 80% and above. So kung nagdugo na siya or spleen lang yung injury and you end up with 1 liter hemoperitoneum when you open it up, kahit hindi na nagbe-bleed yung spleen at yun lang yung injury, you have to remove it already kasi 1 liter na yung dinugo niya. Kung wala kang ginawa at nagre-bleed sa ward, hindi mo na siya maulit madala sa OR because the mortality is 80%. So again, if it's not bleeding, leave it alone. If it's bleeding, remove it. No suturing. No splenophraphies. Next, for the liver, you all know this already. Your piece, your push and press down, your Pringle, your packing, your resectional debridement, and your the tourniquets that you can use or tourniquets, kung anong preference nyo na pronunciation. So the first thing you need to do is you try to, actually the most senior member of the team, if you have a really bad liver, so you try to put it back together and push down really hard using your weight and then assess. Kasi kung hindi nag-stop yung bleeding, chances are hindi mo siya mapapack. Have someone ready to do your Pringle maneuver. Yun. As you can see, no, these are the other options that you can use, no. But for the exam, usually the answer is packing when you make the exam. Kasi most of the liver injuries for trauma, especially for blunt, I managed with packing alone. Again, you try to put them back together, push down using your weight. If the bleeding stops, then the chances of it being packed successfully is higher. So you can do lateral compression, you can do posterior compression. When you have to do hepatic artery ligation, it has to be as close to the damaged liver lobe as possible. Temporary ligation is preferred, no? Pwede niyong lagyan ng vessel loop, or if you have to ligate it, then the right hepatic artery, then you might need to perform your cholecystectomy. So another option is, so this is how your perihepatic packing should look like. And another option is you can do your total hepatic occlusion kung medyo comfortable kayo to dissect. So you can control the inflow and the outflow of blood in the liver. And the last resort would be for your retrocaval injuries, no? You do your aortocaval bypass. Now let's go to the pancreas. So medyo maraming natsugi sa pancreas part ng trauma sa oral exam. So you try to imagine a drawing across here para you can, above it is your pancreatic duct. There's a difference na, for example, nandito sa to the left of your vessel, you can, if that's where the injury is, you can just do your distal pancreatectomy. But if your injury is to the right of the vessel, then sayang kasi itong pancreas na to eh. You can ligate the part ng head kung nagbe-bleed, and then yung other part of the pancreas, you can attach a portion of your jejunum there. So yun yung hindi nakuha ng mga oral exams from before. You can do your distal panc with or without your splenectomy. Sometimes in trauma, parang mas madali if you also remove the spleen because they share a blood supply. Mas duduguin kapag hindi mo siya isasama. For the duodenum or for combined pancreatico-duodenal injuries, the simpler the repair, the better the outcome. That's why hindi na masyadong recommended yung pyloric exclusion. No? Just suture it, put your triple drains. Yun. The pyloric exclusion is only recommended if your patient is very stable kasi magdadagdag ka pa ng anastomosis. And usually, hindi talaga stable yung mga patients with injury to this area. Again, for combined pancreatico-duodenal injuries, if you look at data, the simpler the repair, the better. Or damage control of the severity of the combined injury. Blunt abdominal trauma, CT scan is the key, hindi PM, joke lang. So your blunt abdominal trauma, do your fast first for screening. Total bumaba naman yung mga cases natin for COVID, so you won't be afraid of exposing the patient or you being exposed to a lot of the diagnostic procedures that you will bring the patient to. So fast, and then if it's positive, then you can request for your scan to check for the solid organ injury, and do something to check for if you want to do non-operative management. Dapat wala. Ang first, of course, dapat may gamit ka. May ICU, may OR, may blood bank, and may trauma team if you want to do non-operative management. And you have to prove that there's no hollow viscous injury. CT scan will not do that for you. CT scan is not as sensitive and specific for DPL to check if there is hollow viscous injury. So hindi enough yung CT scan lang for you to commit your patient to a non-operative management. Missed bowel injury confers a very high mortality. So ang goal talaga natin before tayo magmaganda at mag-non-operative management ay dapat walang hollow viscous. You can do diagnostic lab kung wala kang TBI kasi the infusion of your CO2 will affect your traumatic brain injury. You can do DPL pag walang DPL sa inyo and your CT scan with contrast is inconclusive, then you might be safer with opening the patient up already kasi hindi mo na fulfill yung number 1 criteria for non-operative management, which is to rule out hollow viscous injury. Okay? Yun. So just a few examples from previous oral exams. We will not deal with that too much. Yeah. So again, for equivocal blunt PE, very hard to conclude na by PE alone, acute abium patient for blunt kasi sobrang daming masakit pag blunt. The only thing that we can accept na bubuksan mo na kaagad is if your patient is hypotensive or fast positive ka, there's bleeding in the abdomen. Or there's florid peritonitis, parang PPU, sobrang tigas, and you're highly considering a bowel injury or lumabas na yung bituka. Now, for equivocal abdomen, you also have this slew of diagnostics that you can use. Yan. Again, CT scan is not really recommended. I mean, yung serial P is not really recommended kasi masakit ang tiyan pag blunt. The first line would be an ultrasound. If positive, we request for a scan. And then once we see the solid organs, our next goal is to look for the hollow viscous injury by either performing your DPL or your diagnostic lab kung walang traumatic brain injury. Kung hindi mo kaya yon, then you're better off doing a next lap. Kung hindi mo siya ma-prove na walang hollow viscous injury, using your less invasive diagnostics. Again, having a non-therapeutic laparotomy is better than a dead patient because you missed the bowel injury. Yeah, so for this case, there's fast positive. That's why they did DPL on this patient and CT scan as well. So hindi na natin this is an oral exam kasi, so we'll not dwell into that. So ito yung sinasabi ko sa inyong spleen, pag if it's bleeding, after packing, kasi nakalagay niya still bleeding, ibig sabihin na pack mo na siya. So the next step will be splenectomy na talaga. If the patient is bleeding, wala pang still, ibig sabihin hindi mo pa siya na-pack, then you try to pack your spleen, especially for blunt trauma. If the bleeding stops at hindi naman hilar yung injury, then that's the time we preserve the spleen. Now, we don't operate based on CT scan findings alone. We have to correlate it as well clinically, kaya nasa ICU yung mga non-operative management. If the BP becomes palpatory while doing all these maneuvers, we all know the answer to that, and it is damage control surgery. So sometimes we ask some critical care questions when we talk about DCS. But bilisan na lang natin, so we will not go over time. So DCS, your goal is to bleeding first, then you tie off your bowels, and then you temporarily close your abdomen. Yun, and then you resuscitate the patient in the ICU. Yan. So anyway, we will have sample questions later on after your series of lectures. So don't you worry, I will be giving a copy to Sir Billy of the lectures, including yung chapter 2 ng Schwartz, where your endocrine and metabolic response to injury, dun namin usually kinukuha yung questions. I hope this review was helpful to you. Thank you very much for your time and your attention.
Wow, thank you, Ma'am Ai, for this very high yield lecture. So these topics are usually very difficult to understand, but with the way that you presented it, parang mas madali na intindihin. And you've essentially covered the whole critical care and trauma in just 1 hour. Amazing. So if you have any questions for Ma'am Irene, please write them in the Q&A box. I hope everyone is listening kasi maraming tips na binigay si Ma'am. So in the meantime, since there are no questions yet, we will go to the practice exam, Sir Billy. So we will be giving you 5 minutes to answer these questions, and then we will call back Ma'am Irene to discuss the answers, okay?
Please try to answer your poll kasi at least I will know yung baseline knowledge ninyo. I know where to start when I make the exam, and it will be fair for you guys. Kasi kung hindi kayo mag-participate, then hindi nyo in-answer yung questions, I won't know na it was too difficult for you or it was too easy. So again, we want to be fair to you guys as much as possible. So please try to answer the poll before we discuss the answers. Thank you po.
Okay, Sir Billy, maybe we can show the results. Okay, let me read the question, Ma'am Ai. Pahinga po muna kayo and then you discuss the answer later on. So question number 1, a 33-year-old male presents to the ER with a gunshot injury to the abdomen. At laparotomy, a deep laceration is found in the pancreas just to the left of the vertebral column with severance of the pancreatic duct. What is the next step in management? So most of them answered distal pancreatectomy. Ma'am Ai?
Okay, so that's correct, no? Sabi ko kanina, basta to the left of the vertebral column, then you can do a distal pancreatectomy. But if you're on the right of the vertebral column, medyo marami kang options na iisipin. Cholangiogram, probably not too helpful when you deal with pancreatic duct injuries. The fact kasi na sinabi, deep laceration, so probably debridement and drainage of the defect won't be enough unless you're having damage control surgery, just put in a drain. But for this case, the correct answer is distal pancreatectomy. So very good. Mukhang papasa na
Ay,
kayo.
pumasa. Thank you, ma'am. So question 2, a 39-year-old female at 29 weeks AOG is stabbed in the right subcostal area. At the ER, her BP is 80/50. She is extremely agitated and yelling that she's going to die. The breath sounds on the right chest is decreased and with diffused abdominal tenderness. The next best step is letter C. Most of them answered letter C. Ma'am?
Correct, no? If we'll run this patient through primary survey, if you have an option there na assess the airway or put oxygen support, then that's the correct answer. Pwede din sana yung intubate the patient except for cases like this, no? Because this is a tension pneumothorax case. If unahin ninyo yung intubation, the patient will arrest because of positive pressure ventilation. Ang clue dyan, kasi the patient was yelling, ibig sabihin the upper airway is clear. So you can forgo with intubation and address the tension pneumothorax, which is needling on the right chest. Insert two large bore IV lines, that's already in your circulation. No? So hindi siya mas priority yung tension kasi nasa breathing and ventilation yun. So the next best step is to do your decompression, your needle D. So intubate all except for patients with tension pneumothorax kasi you will aggravate the tension. After you intubate, the patient will arrest. Unless sabay, nag-intubate ka, may nagni-needle na. Thank you.
Thank you, ma'am. Third question, a 35-year-old female was punched in the right side of the abdomen and chest. PE showed positive right upper abdominal tenderness with no guarding or rebound tenderness. Gastrography and upper GI study showed a coiled spring or stack of coins appearance of the second and third part of the duodenum. What is your most likely diagnosis?
Okay, so ito direct recall. So for the first years, ito na mga question. Usually the stack of coins appearance, if you Google that, since madali na tayong mag-Google ngayon, it's usually a pathognomonic sign for duodenal hematoma. So duodenal hematoma, hindi natin kailangan galawin. We just wait for the hematoma to recover. So sometimes it will take a month before we can feed these patients enterally kasi nag-obstruct because of the hematoma, but it usually resolves in a month or less. So again, stack of coins, usually very common for blunt abdominal injury na sa epigastric area. And you usually get duodenal hematoma. Thank you.
Thank you, ma'am. Fourth question, the most common cause of AKI in critically ill patients.
Okay, so maraming nag-answer ng hypovolemia, but the correct answer is sepsis. So for critically ill patients, ito yung mga pasyente na pinapasok natin sa ICU, usually because of severe infection. And although a part can also be attributed, for example, for trauma or who come in class 3 or 4 shock, but ang ano kasi is the most common. So the most common is still sepsis, pumapangalawa lang yung hypovolemia.
Na-confuse sila doon, ma'am. And now for our last question, a 67-year-old male with CHF is admitted to the CCU after a segmental small bowel resection for ischemia. The patient has a central line placed along with an arterial line. The normalization of this value is most consistent with successful fluid resuscitation. Most of them answered lactate.
Okay, very good. So, favorite ko talaga ang ABG for critically ill patient because the base deficit is surrogate for lactate. Although may hospitals na may lactate na kung nasa St. Luke's ka or sa Asian, you can easily request for that. But for those who are training in a government institution, sobrang mahal. So you can request for your ABG and look at your base deficit. Studies have shown that it's a very good correlation for lactate levels. And that's the best surrogate lab result that we can look into for normalization or resuscitation endpoint. So kung gumanda yung base deficit mo from a -11, which we consider as marker for mortality in critically ill, tapos naging -6, then you've successfully somehow resuscitated your patient.
Thank you, ma'am.
Okay, thank you.
So, if there are no questions, in the interest of time, we will now move on to our second lecture. Thank you ulit, ma'am.
Happy birthday ulit.
Salamat po. So for those who are just joining us, again, welcome to the PSGS review course. Our next lecturer, Sir Billy, can we project the slide? Okay, Dr. Kelvin Uy is a graduate of Cardinal Santos Medical Center. He finished his fellowship training on colorectal surgery in Rizal Medical Center and is currently a medical specialist 2 of the said institution, as well as an active consultant of Cardinal Santos Medical Center. So to talk about colorectal and anus, Dr. Kelvin Uy. Sir?
Good afternoon, everyone. I would like to thank PSGS Metro Manila chapter for inviting me to give a talk regarding colon and rectum diseases. Also, I'd like to thank Dr. Gretel for that kind introduction. So today, we'll talk about colon and rectum diseases and overview. So first, we'll talk about diverticular disease. Diverticular disease is defined as a presence of symptomatic diverticula, while diverticulosis is a presence of diverticula without an inflammation. While in diverticulitis, there is an inflammation and infection associated with a diverticula. Diverticulitis, 10 to 25% of people with diverticulosis develop diverticulitis. This is a peridiverticular and pericolic infection that leads to perforation of diverticulum, whether it's a macro or a micro, which also leads into contamination, inflammation, infection, ranging from mild, uncomplicated diverticulitis to free perforation and diffuse peritonitis. It is said that at age 60, 40% develop diverticular disease, while at age 80, 60% develop diverticular disease. And out of this is 20 to 25% diverticulosis will eventually develop into diverticulitis. In 95% of diverticular disease, this is found in the sigmoid colon or the left-sided colon, while 35 to 40% complicated diverticulitis recur. It's usually presented with a left-sided abdominal pain, leukocytosis with or without fever or a palpable mass. CT scan is still the recommended modality of choice to define pericolic inflammation, phlegmon, or any abscesses. It is highly sensitive, specific, and low false positive. X-ray may be also important in determining if there's any presence of pneumoperitoneum, but contrast enemas and or endoscopy are relatively contraindicated because of the risk of perforations. In uncomplicated diverticulitis, left lower quadrant abdominal pain or tenderness with a CT scan finding of pericolic soft tissue stranding, colonic wall thickening, or phlegmon. Usually, if without any systemic symptoms, You can treat patient as an outpatient with broad-spectrum oral antibiotics and low-residue diet. But 10 to 20% had more severe abdominal pain with fever and mucositis. These are the patients that you admit them, place them on NPO, and start on parenteral antibiotics. Most patients will recover without surgery. 50 to 70% will have no further episodes, and one-third will recur within 1 year. Previous guidelines regarding when to do surgery in uncomplicated diverticulitis shows that they recommend that after the second episodes of uncomplicated diverticulitis, or after the first episodes in very young patients, after the first episodes of complicated diverticulitis, and after the first episode in immunosuppressed patients. But currently, there are newer guidelines when to do elective surgery for acute diverticulitis. The decision is to recommend elective sigmoid colectomy after recovery from uncomplicated diverticulitis should be individualized. Current indications for doing an elective surgery includes post-transplant patients for chronic steroid use, immunocompromised patients, or your inability to exclude carcinoma, or having a chronic lingering symptoms. Because colon carcinoma may have an identical clinical presentation to diverticulitis, all patients must be evaluated for malignancy after resolution of the acute episode. So when is this? It's around 4 to 6 weeks after recovery, then you subject the patient for a flexible sigmoidoscopy or a better yet a colonoscopy to exclude malignancy. Because inability to exclude malignancy is already an indication for resection. So you want elective sigmoidectomy with primary anastomosis is the procedure of choice. That's the ideal. So how would you determine if your line of resection? So for the distal resection, we usually advise you stop at the upper rectum. The risk of recurrence is high if the segment of a sigmoid colon is retained. For the proximal extent, all thickened and inflamed bowel must go, and you can stop when the tissue is soft and pliable. You don't have to resect all the diverticula seen. As long as it is soft and pliable, then you can stop at that resection margin. So for complicated diverticulitis, it is defined as having an abscess, peritonitis for free perforations, obstruction, or fistulas. Abscess and peritonitis, as abscess with less than 2 cm by CT scan can be left alone and treated by parenteral antibiotics. Abscess more than 2 cm is usually advised for a percutaneous drainage. In this aspect, we try to avoid emergency surgeries and avoid a multi-stage surgery, which will result with a stoma. So when do we do emergency laparotomy for complicated diverticulitis? When the abscess is inaccessible to percutaneous drainage, when the clinical condition deteriorates in spite of the medical treatment, clinical conditions fails to improve, there's a presence of pneumoperitoneum or signs of peritonitis or peritoneal signs. So in CT scan, it also gives us staging of the abscess. You might be familiar already with this. There is a Hinchey staging 1, 2, 3, and 4 as follows. Usually, stage 4 is an intraoperative staging. You can only note the fecal peritonitis on opening up the patient. So the treatment as for the staging of the Hinchey staging system, stage 1 and 2 are candidates for sigmoid colectomy with primary anastomosis, one-stage surgery after you treat them medically. But for stage 3 and stage 4, usually we do an emergency surgery with results to Hartmann's procedure, which is, as you know, it's very difficult to reverse. But there are some studies showing success has been reported with a sigmoidectomy with an on-table lavage with a proximal diversion. But this is case-to-case basis. It really depends on the condition of your patient. In extremely unstable patients or in the presence of such severe inflammation that resection would harm adjacent organs, a proximal diversion and a local drainage have been used. However, this approach is generally avoided because of higher morbidity and mortality rates, along with requirements for multiple operations. So one of the complications also of a diverticulitis is on obstruction. Partial obstructive symptoms in 67%, So we start with fluid resuscitation, NGT decompression, and low volume water soluble contrast. If there's a relief of obstructions, allows you to do a full bowel prep for an elective resection. Remember, you have to be careful in doing a high volume oral bowel prep, as you may push your patient to an absolute obstruction or a complete obstruction. Patient usually present in 10% of the time as complete obstruction or failure of conservative management, then you do surgery, which as of now is still the safest, is to do a Hartmann's. But other proponents said that if you have a stable patient, healthy proximal distal bowel, with good nutritional status, a sigmoidectomy with primary anastomosis with an on-table lavage or a proximal diversion is also an option. Right-sided diverticula are more often seen in younger patients than do left-sided, and they're more common in Asians than Caucasians, and most patients are asymptomatic. Usually, we find them out during intraoperative surgery for a diagnosis of an acute appendicitis. So if you have a case like that, the preferred treatment for a right-sided diverticulitis is an ileocecal resection with primary anastomosis. Also, one of the options is a diverticulectomy. If you only have a single large diverticulum with minimal inflammation, which may be probably an option. So this is a schematic algorithm of the symptomatic diverticulitis. On the blue side, on the left side of your screen is the uncomplicated, while the right side is your complicated arm. Okay. So we go now to the next topic, volvulus. Volvulus is an air-filled segment of the colon twist about its mesentery. Most of the time, it is found in the left side, involving the sigmoid colon in 90% of the time. It may reduce spontaneously, and bowel obstruction develop when there's a closed loop, causing strangulation, gangrene, or perforation. Acute bowel obstruction, presenting with abdominal distension and vomiting, rapidly progress to generalized abdominal pain and tenderness. Fever and leukocytosis and heralds of gangrene and or perforation of the closed loop obstruction. So you can see sigmoid volvulus by an X-ray, a plain abdominal X-ray, when you see a bent inner tube or a coffee bean appearance with the convexity of the loop lying in the right upper quadrant. A gastrographin enema have a pathognomonic bird's beak sign, as you can see. So the initial management for volvulus is resuscitation, followed by endoscopic retorsion. If it's available, if it's not, you can also perform your rigid proctosigmoidoscopy with care. Then later on, after a successful retorsion, it is advisable to place a rectal tube for decompression. The risk of recurrence for sigmoid volvulus is around 40%. That's why we advise an elective sigmoidectomy on the same admission. But remember, before sending your patient for endoscopic retorsion or performing a rigid proctoscopy, you have to be sure that you have no clinical evidence of gangrene or perforation, which mandates an immediate surgical exploration without an attempt at endoscopic retorsion. So if there's a presence of necrotic mucosa during your initial insertion, or a dark blood on your endoscopy or during your rectal examination, then you don't attempt to further the endoscopic retorsion. You will send the patient for an emergency laparotomy because maybe your bowel is already strangulated. So when you do a emergency surgery, usually patients end up with a Hartmann's procedure. It is still the safest operation, especially if it's ischemia, infarction, gangrene, perforation, or peritonitis. Next topic is the rectal prolapse, also known as first-degree prolapse, complete prolapse, or presidentia. In rectal prolapse, it is described as a circumferential, full-thickness protrusion of the rectum through the anus. Internal prolapse is a rectal wall intussuscept but does not protrude, while mucosal prolapse is a partial thickness protrusion associated with hemorrhoidal disease. So female has more ratio in proportion to male is 6:1, and it peaks usually in the 7th decade of life, while the male is found out to be unrelated to age. Usually, patient complains of sensation of tissue protruding from the anus, sensation of incomplete evacuation, tenesmus, mucus discharge, or leak, with myriads of functional complaints. The anatomic risk factors for rectal prolapse are large redundant sigmoid colon, deep pouch of Douglas or Coulson, laxity of rectal attachment, or lack of fixation of the rectum to the sacrum. Diagnostic test for a rectal prolapse is doing colonic transit studies, anorectal manometry, pudendal nerve terminal motor latency, cinedefecography, colonoscopy, or barium enema to exclude neoplasm and diverticular disease. Rectal prolapse surgeries, there are more than 100 surgical procedures actually described in the textbook. Usually what dictates what kind of surgery we'll perform to the patient is by the cardiopulmonary condition or the overall medical condition of the patient. And the comorbids influence the choice of the surgical procedure. So to name a few, the most common one is the abdominal rectopexy with or without resection. This may be the rectopexy may be performed using a suture or a mesh, laparoscopic or open. This is as of now, this is the most durable repair with a recurrence rate of less than 10%. Abdominal rectopexy with or without resection have many other procedures like Moshkowitz, Ripstein and Wells, suture rectopexy, resection of redundant sigmoid colon, resection with rectopexy, whether you use a suture to pexy that rectum or a mesh, open or laparoscopic approach. Another approach, aside from the abdominal, as we have mentioned earlier, is the perineal approach. This one is preferably for higher risk patient who has lots of comorbids, but the downside is higher recurrence rate siya. So there are several perineal approach. The most common is the Delorme and the Altemeyer. The Tirsch is already a historical procedure. It uses an anal encirclement with wire, which produces a lot of complications. So we usually use the Delorme or Altemeyer. The Delorme is reefing of the rectal mucosa, and while the Altemeyer is perineal rectosigmoidectomy. So these are the perineal approach. So how would you know when to do an abdominal versus a perineal approach for a rectal prolapse case? So usually this is dictated by the patient's comorbidities or age, the bowel function, and surgeon's preference and experience. So this is an algorithm of how we go about a rectal prolapse. Important here is the history in PE. In history, you really have to know if the patient is incontinent prior to the prolapse or constipated prior to the prolapse. Then you can also do your diagnostics, fluoroscopy, MRI, colonoscopy. And if you have a young patient with no comorbids, then you can approach it abdominally. If it's with incontinence, you may do a rectopexy. If it's with constipation, maybe a resection might help also. Okay? If you have an advanced age or poor surgical risk, then the perineal approach might be better for that patient. If it is said that if it's less than 5 cm protrusion, then a Delorme procedure will do. Then if it's a more than 5 cm, an Altemeyer procedure might be better para you can resect the redundant sigmoid. And if it's with incontinence prior to the prolapse, then maybe you have to add levatorplasty on your procedure. So the next topic is ostomy. Ostomies are created temporarily or are permanent. You can use an end, loop, or a double barrel. You can use a colon or a small bowel. There's so many choices or options for ostomy. Irregardless of the indications, placement and construction are crucial to function. So ideally, you place your colostomy within the rectus muscle to minimize parastomal hernia. Place it where the patient can see it and easily manipulate the appliance. Flat surface as much as possible to ensure a tight seal and prevent leakage. So for me, a preoperative stoma sighting is very, very important because properly chosen stoma location is the most important predictor of an estimates the quality of life to the patient postoperatively. Okay? So in ileostomy, when do we do a temporary protecting ileostomy? We usually do that if you have a distal rectal anastomosis, you have a patient who underwent a neoadjuvant chemo-RT, or you have an immunocompromised patient or a malnourished patient, or sometimes in some emergency situation, whether to use a loop or a double barrel in divided. Actually, study says there's no statistical difference between the two. We also use temporary protecting ileostomy when we have a difficult operation for a low-lying tumor in the rectum. We have a narrow male pelvis, or any technical or complications during the surgery. When patient had neoadjuvant chemo-RT, or when you're performing a total mesorectal excision, or TME. But remember, in creating a temporary protecting ileostomy, it does not decrease the incidence of anastomotic leak. But by doing a protective ileostomy, it does decrease the morbidity of the patient in anastomotic leak. Sometimes you don't even have to do re-op. You just maybe perform a CT image-guided percutaneous drainage of that leak. Okay. So the question another is timing of closure. So usually, when do we close? When there is anastomotic healing. So you have to check the anastomosis prior to closure by performing a colonogram or flexible sigmoidoscopy. Patient's overall condition should be better, the nutritional status, and usually we opt if the patient has already completed his adjuvant therapy. When do we do permanent ileostomy, or what we call an end ileostomy? This is usually performed after a total proctocolectomy in patient with unresectable obstruction distally. So we see these cases usually in fat cases. So when you perform if you know that you're going to perform a permanent one, it is advisable to perform a Brook ileostomy as the illustration showed, for better appliance fitting. So we go to complications. There are several complications of stomas. One is stoma necrosis. Usually you see this early postoperative period. You see this, if it's early, it's usually secondary to a skeletonizing the small bowel too much. Then you devascularize it, or your fascial opening is very tight. So you can do a bedside test tube examination. You place a test tube inside, shine a flashlight inside, and look for the level of necrosis. If it's a if it's above the fascia, then maybe you could expect that management. Maybe it will hold. But if it's below the fascia, then you have no choice but to do a surgical revision. Stomal retraction is another complication which may be exacerbated by obesity. Local revision may be necessary. Another complication of ileostomy is dehydration and fluid and electrolyte abnormalities. Because it bypasses the fluid absorbing capability of the colon, so the ideal output of your ileostomy should be at least 1.5 liters per day. So if it's more, then you start on your fluid replacement, electrolyte replacement. You can also use bulking agents. Some studies say also you can use octreotides. Another complication is the skin irritation, because remember, the sucus from the ileum is very irritant to our skin. So this happens especially if the appliance fits poorly. So you can use some skin protecting agent, calmoseptine, duoderm, or such. Or others might need some customized pouch, especially for obese patients. So it's very important yung sinasabi kanina na stoma sighting to prevent these complications. Parastomal hernia. This is less common in ileostomy. We see this more common in colostomy. It can cause poor appliance fitting. It can cause pain, and sometimes obstruction or strangulation. If the patient is already symptomatic in regards to obstruction and strangulation, sometimes surgery is needed, and resighting to the contralateral side is warranted. So in colostomy naman, we have the distal mucous fistula or the Hartmann's pouch, and the loop colostomy. But the problem with loop colostomy usually is bulkiness of the colon, so which makes the appliance very hard to apply, yung colostomy bag. And prolapse is more likely compared to an ileostomy. And another complication is necrosis, the same as the ileostomy. And I like to reiterate, aside from the mention above, yung mga complications, how to do it, placement of the ileostomy properly, also the choice of diversion. If you're given a case of obstruction, as a surgeon is called in for diversion. So for me it's very important where we will divert. For example, if you have a patient with a very low tumor around 2 cm, 1 cm from the anal verge, obstructed, or if with liver metastasis, that you know that patient will be undergoing neoadjuvant chemotherapy, but you have to divert. So where will you divert? For me, best option is a sigmoid, because later on maybe the patient might have to undergo your definitive surgery of an APR, then if you created the sigmoid loop colostomy, that will be your end colostomy in the future. You don't have to take it down anymore, or you don't have to resect more, no? More colon. So for our next topic, it's a molecular basis of the colorectal cancer and overview of inherited colorectal cancer syndromes. So colorectal cancer is a genetically heterogeneous disease that arises via at least three main oncologic pathways: chromosomal instability, microsatellite instability, and methylator phenotype. Edematous polyposis syndromes, these are the FAP. It is an autosomal dominant hallmark feature of is colorectal adenomatous polyposis. Um, it is diagnosed genetically or clinically. It has 100% colorectal cancer risk at a median age of 32. So you usually start screening at age 12. Surgical removal is still the mainstay of treatment. So these are the following subtypes of FAP. Screening and surveillance for colorectal neoplasm. It is found that screening can reduce colorectal mortality. Screening recommendations are based upon risk for polyps or cancer development. Surveillance after polypectomy depends on the histology of the polyp and the completeness of resection. So it is said that screening allows for early detection of colorectal cancer and removal of precancerous lesions, leading to reductions in cancer incidence and mortality. Colonoscopy is both diagnostic and therapeutic. It allows visualization of the entire colon and terminal ileum, and it decreases the risk of colorectal cancer incidence by 76 to 90% because you're able to take out that polyp. No? So it is still the best diagnostic tool to detect even a sub-centimeter polyps versus a barium enema or a virtual colonoscopy, which has higher miss rate. It is non-therapeutic and not shown to decrease mortality. So recommendation for screening, you have three kinds of classification. One, the average risk, the increased risk, and the high risk. So in average risk, the recommendation for screening is at age 50 and above. So average risk, you will fall into this category if you have no history of adenoma, no family history of colon cancer, and no history of IBD. For increased risk naman, if you have personal history of adenomas or colorectal cancer before the age of 60, any family history of cancers, and history of IBD. And for the high risk, if you have colorectal cancer before 50 years of age, or personal or family history of polyposis syndromes, which are the FAPs. No? So in the average risk, the screening modality we usually advise are FOBT annually, flexible sigmoidoscopy every 5 years, colonoscopy every 10 years, CT colonography every 5 years. Okay? For increased risk patients, you should start screening by the age of 40 or 10 years prior to the youngest case. So for example, your father or your mother or your first degree relative has cancer in like 45 years old, then you should start your screening at the age of 35. For high risk patients, positive FAP or suspected FAP, screening should start at the age of 10 to 12 years old. For Lynch syndrome, screening should start at the age of 20 to 25 years old or 10 years prior to the youngest case. Okay? So different timing of screening yun. So we talk about polyps. Not all polyps are premalignant. There is a hyperplastic, inflammatory, hamartomatous polyps or neoplastic or the adenomatous. So we talk about the adenomatous polyps. which occurred in 24 to 50% of the population older than 50 years old. Dysplastic is a low-grade dysplastic lesion with the potential for progression to an invasive malignancy. So you usually have two kinds of um, you have usually two types of polyps. No? So you have the pedunculated, the mushroom-like on stalk, and a sessile, which have a broader base. So for the polyps, you have the following tubular, tubulovilus adenomas, and villus adenomas with the following risk of malignancy, as you can see on your screen. But while the likelihood of a polyp to harbor malignancy be impacted by this classification, the treatment for the three classes remains the same and thus has little true clinical significance. All adenomas or apparent adenomas should be completely removed for confirmation of diagnosis, to exclude concurrent malignancy, to determine the need for further intervention, and to preclude malignant degeneration. So if you're presented with a pedunculated polyp, usually they do a snare excision, colonoscopic or endoscopic snare excision, while the sessile polyps is a little bit more challenging. You have to do a saline lift, and sometimes you have to perform an endoscopic submucosal dissection. For the adenomatous polyps that needs colectomy, those are the colonoscopic removal is impossible, such a large flat lesion, so you cannot take out everything. Or if there is a focus of invasive cancer that is confirmed in the specimen, then you have to go back to the patient for a proper colectomy. And these are the ideal patient for the laparoscopic colectomy. So usually, if you have a malignant polyp in the colon, so the workup should be a pathological review of the histopath, the colonoscopy, and, and ideally marking of the cancerous polyp site at the time of colonoscopy. Remember, the polyp is already removed, so when you do your surgery, you cannot really appreciate it, or you cannot feel it during your surgery. So it might help if you have a markings. And all patients should be counseled for family history and risk assessment. So if you have a single specimen completely removed with clear margins and favorable histological feature, endoscopically removed, so there's option for observe if you have a pedunculated polyp with invasive cancer. Then if you have a sessile polyp with invasive cancer, then maybe you can observe or do a colectomy. So observation has significantly greater incidence of adverse outcomes, residual disease, recurrent diseases, mortality, and hematogenous mets. No? So, but when you have polyp that are fragmented specimen or margin cannot be assessed or unfavorable histological features, then you have to perform a colectomy. So what are the unfavorable histological features? Grade 3 or 4, which are poorly differentiated or undifferentiated, angiolymphatic invasion, positive margin of resection, which is defined of less than 1 millimeter from the transected margin tumor cells present within the epithermy of the transected specimen. So in colon cancer, appropriate for resection, preferably with histological confirmation of primary colonic malignancy, no distant mets. So usually review the pathological result, perform colonoscopy, and then the following examinations. Remember, CEA is not a good test to screen colorectal cancer. It is used as a standard to identify recurrent colorectal cancer following surgery. So this is for monitoring response, monitoring the treatment response. So surgical plan appropriate, colon cancer appropriate for resection if there is no distant mets. If it's resectable and non-obstructed, then you go ahead with your colectomy with primary anastomosis as a primary choice of surgery. If it's resectable and obstructing, then colectomy with primary anastomosis can be considered using an on-table lavage, especially for left-sided lesion, or you can do your resection, anastomose, and proximal diversion, or you can also perform or subject patient for stenting, endoscopic stenting to bridge for a surgery, for a one-stage surgery with anastomosis. So what are the principles of surgery for colon cancer? Colectomy with an en bloc removal of all associated regional lymph nodes and involved adjacent structures. The length of the bowel resected is governed by the blood supply with a minimum of 5 cm margin on both sides of the tumor. The mesentery should be removed to the origin of the primary feeding vessels. So, what is a complete mesocolic excision for colon cancer? Surgical technique with sharp dissection on the visceral plane from the retroperitoneal one, aiming finally to avoid any breaching of the visceral fascial layer, which potentially may lead to tumor spread with peritoneal cavity. The origin of the colonic arteries can be well exposed and tied centrally at their origin to ensure maximal harvest of the regional lymph nodes. So this is a picture of a complete mesocolic excision specimen. As you can see, there's a very wide mesocolic margin, and the vascular ties or the vessel are ligated usually at its roots. So central ligation of supplying vessels, if you have a right-sided, you tie it at the ileocolic or the right branch of the MCA as it exceeds its roots. No? So the following. For the left-sided, usually we tie it on the IMA or the IMV. Regional lymph nodes involvement, most common form of spread, precedes distant metastasis or carcinomatosis. The risk factors are the tumor size, poorly differentiated histology, lymphovascular invasion, depth of tumor invasion. So this is TNM staging for colorectal carcinoma with a 5-year survival. So as you can see, if you have lymph nodes, stage 3, 5-year survival is around 39 to 60%. Poor prognostic factors are mentioned as poorly differentiated, mucinous signet ring, vascular invasion, or DNA aneuploidy. So when you have a pathologic stage of the T staging, for to guide you when to offer adjuvant therapy, usually in T1 or T2. No, there's no need for chemotherapy. But T3, which is still T3 NOMO is still stage 2 with no high risk features, then maybe observation without chemotherapy. But if with high risk feature for systemic recurrence, then chemotherapy is warranted. Likewise, a T4 lesion. Okay, so what are the high risk feature for stage 2 are T4 lesions, poorly differentiated, grade 3 or 4, angiolymphatic invasion, positive margin of resection, or less than 12 lymph nodes examined, or patient presented as bowel obstruction or perforation during preoperatively. So those are the high risk feature. Even if the patient is stage 2, we offer them adjuvant treatment. So in colon cancer M1, which means metastatic, the workup are as follows. And the important I want to stress on this part is the MDT. If you get colon cancer with suspected or even suspected lang or proven metastatic, an MDT is very important. So you include all other specialties to be involved in the case. So in M1, suspected or proven metastatic includes adenocarcinoma with resectable primary and distant mets. Then maybe options are as follows: colectomy with synchronous liver and lung resection, followed by chemo, colectomy with stage liver and lung, followed by chemo, or systemic chemotherapy first, usually 2 to 3 months, followed by surgery. So I think this will be decided upon your MDT. So there's no one size fit all procedure to the patient. It's we usually individualize our treatment to the patient's conditions. No? Okay. So like this one, if you have a M1 suspected with carcinomatosis not obstructing, maybe you can offer chemotherapy. But if even with carcinomatosis and obstructed or imminent obstruction, maybe you can perform a palliative resection, diverting ostomy, bypass, or even stenting, then followed by chemotherapy. So what's the role of cytoreductive surgery and HIPEC? Currently, it is only recommended for the treatment of appendiceal adeno-CA with peritoneal dissemination and pseudomyxoma peritoniae. It should not be considered as a standard of treatment at present, but it can be considered in peritoneal metastasis. It can be considered in experienced centers for select patients with limited peritoneal mets for whom an RO resection can be achieved. Okay, so what is the role of RT in colon cancer? As of now, in NCCN 2020, um, it has a role in a very select patients for T4 tumors that would which are penetrating to a fixed structure or recurrent disease. No? According to ASCRS, RT plays a limited role in patients with colon cancer, um, usually on T4 tumors. So regarding surveillance, you can read it on your NCCN guidelines. I just want to point out that PET CT should only be used to evaluate an equivocal finding on a contrast-enhanced CT scan or in patient with strong contraindication to IV contrast. Okay, so we go to our last topic. I think this is my last topic, rectal cancer. So we define rectal through their anatomic definition. So upper rectum, 11 to 15, mid rectum, 6 to 10, 0 to 5 is the lower or the distal rectum. So measurement is really based on the most distal extent. No? So we work up malignant polyp in the rectum as follows. No? Uh, so CT scan for rectal cancer. The accurate of T staging is for me, is quite low, 52 to 94%. Nodal staging is around 54 to 70%, but the distant metastasis is very excellent in performing a CT scan for rectal cancer. The limitations is there is a low accuracy for the invasion of the CRM, especially in low anterior located tumors. There is also high inconsistency among readers, while MRI is the more accurate in predicting the tumor involvement of the CRM with 94% sensitivity and 85% specificity. Um, Nodal staging also is good, 39 to 95%, but micrometastasis can occur in normal sized nodes and cannot reliably differentiate between a lymph node mets or a separate extramural tumor deposit. While endorectal ultrasound uses a rigid probe or a flexible echoendoscope, its stage accuracy is around 63 to 95%, but study says it overstage of T2 lesions. But the limiting factor is that it limits by a stenotic lesion or obstructing tumors. Kasi in performing endorectal ultrasound, the probe should pass through your tumor to get a 3D or a 360 degrees reading to accurately see the tumor. Okay, so the principles of is a neoadjuvant treatment improves oncologic outcomes after TME. You can use a short course RT, but it is said to have a higher toxicity and morbidity. If you want for a downstaging of your rectal tumor, then you have to use the long course RT. Patient selection is very important. Treatment is tailored according to size and location of the tumor. So preoperative staging is very important in rectal cancer. CT has a lower accuracy for local staging of rectal tumors, but more useful for distant metastases. MRI and EUS, or the endorectal ultrasound, have a comparable accuracy. EUS is better for early cancers like your T1 to T2, while MRI are better for advanced cancer and for better in reading the CRM, the circumferential radial margin. In malignant polyp of the rectum, if you have a T1 lesion only diagnosed in your endorectal ultrasound, you have a single specimen with completely removed with clear margins and favorable histological features, then you can also advise observation. But if it's with a sessile polyp, it's either observe or resect. It's really up to the other features. So remember, if you choose observation, there is a significantly greater incidence of adverse outcomes like residual disease or recurrent disease or hematogenous mets. So this is the same like the earlier slides in the colon for T1, but remember the polyp in the rectum that is amenable for endoscopic resection is for only T1 lesions. Okay. So we can offer transanal local excision or endoscopic excision of a T1 lesion if you fit the criteria. If it's less than 30%, less than 3 cm, margins are clear, it is mobile, non-fixed within 8 cm of the anal verge, with T1 via endorectal ultrasound, and you can endoscopically remove the polyp in total, and no lymphovascular invasion by your ultrasound. You have a well to moderately differentiated histopathological report, no evidence of lymphadenopathy on pretreatment imaging with full thickness excision, then you can offer a transanal local excision. Okay. If it's more than 8 cm from the anal verge, then you can offer a TAMIS. A TAMIS is a transanal minimally invasive surgery. You use a platform for the MIS and the laparoscopic in the abdomen, place it in the anus, and do your excision, transanal excision. Okay? So when do we do neoadjuvant therapy for rectal cancer? So usually give advise neoadjuvant RT for T3, T4 lesion and any N positive uh, rectal cancer. So rectal cancer appropriate for resection, preferably with histological confirmation with no distant mets. So these are the workups. And remember, at the lower bottom, it says an enterostomal therapist referral because usually you end up with a proximal diversion or protecting ileostomy. So rectal cancer, initial evaluation, you perform colonoscopy, biopsy, and histopathological review is very important. Metastatic evaluation of the chest and abdomen using a CT scan. For the pelvic, you use an endorectal ultrasound or a pelvic MRI. PET CT scan is not routinely indicated. CE level is obtained for a baseline. And you do your pre-surgical evaluation using your finger or rectal examination and accurately rigid proctoscopy for leveling. So primary treatment, if it's a T1 with no lymph nodes, you can offer transanal excision. And if you have clear margins, then you can observe. If it's a T1, you perform a transanal excision, it turns out to have a high-risk feature, then you have to go back for a transabdominal resection. Okay? So surgery is still the mainstay of therapy, but with rectal cancer, you have many other options, especially if it's a local um, T3, T4, or higher stage of rectal cancer. Then I think a multidisciplinary team is really very important. No? Aside from rectal cancer with metastasis, definitely an MDT is very important. So you have several options here: chemotherapy 2 to 3 months, stage or synchronous resection of mets and rectal lesions. So this will all be discussed. There's no one surgery fits all. You have to really discuss amongst the multidisciplinary specialties what is the best for your patient. Okay. So even with unresectable synchronous distant metastasis or medically inoperable, if it's symptomatic, you can offer chemotherapy or resect or even divert or offer stenting. For asymptomatic, then you offer chemotherapy. So that will be my last slide. Thank you very much for your kind attention and hope you have a safe day. Thank you.
Thank you, Sir Kelvin, for a very comprehensive lecture. Again, if you have any questions, please write them in the Q&A box. Before we proceed to the practice questions, we have a question from Dr. Anonymous. So for stable patients with Hinchit 2 diverticulitis with retroperitoneal abscess without peritonitis, wherein drainage was done, when should the definitive procedure be done? So, sir, I can see that you have answered this in the Q&A box, but would you like to discuss this further?
Okay, Gretel. Again, happy birthday.
Thank you, sir.
Okay. So as I've answered earlier in the question, thank you for the question. According to your question, that the patient responded medically, if there's no indications like you're able to exclude malignancy, there's no lingering pain, there's no other complications like fistula, obstruction, or retained abscess, then patient can opt not to have surgery. Because nga, as Harry says, it's around 1/3 of them recur only. So yung dating guidelines that the number of attacks dictates surgery, it no longer holds true. It's more of talagang ini-individualize natin treatment according to our patient's response. Okay.
Salamat, sir. We will now move on to the practice questions, Sir Billy. So again, may I request the residents to please answer them. We will be giving you 5 minutes again. Okay, let me cut it shorter in the interest of time. Sir Billy, can we show the results? Sir, let me read the first question. A 38-year-old male came in, diagnosed case of rectal adenocarcinoma, 5 centimeters from the anal verge via colonoscopy. Non-obstructing, what will be your next step? Most of them, sir, answered B.
Yes, that's right. In rectal cases, it's very important we stage the patient properly before offering any kind of treatment, because in rectal cancers, there's many options of treatment. Nandiyan yung neoadjuvant chemo-RT, tapos ngayon may bago na mga with concurrent chemotherapy, or you can go out for outright surgery. So very important dyan is staging, proper staging. And in rectal CA, best staging pa rin ng ERUS or the endorectal ultrasound or MRI compared to a CT scan. CT scan, we use only that for distant mets, ruling out distant mets.
Sir. Second question, a 45-year-old male came in due to hematochezia, and the rectal ultrasound showed a 2-centimeter mass at 5 centimeters from the anal verge, invading up to the submucosal level. There were no lymph nodes seen. What will be the best next step? Again,
Okay.
most of them answered B, transanal excision.
Oh, again, it's correct, no? Transanal excision can be used in this case. 2 cm, no? Di ba, yung kanina I showed the parang itemized ng criteria for offering a transanal excision, which this falls into that category. 2 cm within 5 cm margin, from the anal verge, less than 30% ng circumferential involvement, and you're able to take the whole thing in one piece. No? So a transanal excision can be done for this patient and depends on your final histopath that you will see if you will recommend for a colectomy or just an observation afterwards.
Thank you, sir. Next question. A bedbound 89-year-old female with dementia came into the ER due to lack of bowel movement. The patient had distended hyperactive tympanitic abdomen with tenderness at the left hemiabdomen. DRE showed collapsed rectal vault with no mass or blood. X-ray showed a coffee bean sign. So what is the appropriate management? Most answered B, endoscopic detorsion with rectal tube insertion. Sir?
So that's again correct, no? With the diagnosis, for me, for the case, I think the diagnosis they arrive is a sigmoid volvulus. So that's why an endoscopic detorsion with rectal tube can be attempted since your rectal examination doesn't produce any blood. Tapos yung abdomen nyo is not rigid or no signs of peritonitis, then you can opt for an endoscopic detortion.
May mga maraming papasa, sir, no?
Yun nga eh, mukhang mabilis ata yung pinagay na.
Ang galing ng lecture niyo, sir.
Magaling lang sila talaga.
Wow, okay.
Yeah.
Sige. Fourth question po, a 65-year-old female came in due to obstruction secondary to colorectal cancer, 2 centimeters from the anal verge. Which diversion would be the best for the patient? Most answered C, sigmoid loop colostomy.
For this, the question, I mean, the transverse loop, the loop ileostomy, and the sigmoid loop colostomy, all can be parang acceptable answer. But the best I think is for a sigmoid loop. I agree. Kasi if you're patient, if you're thinking in the long run, your definitive surgery will be a sigmoid loop, then it's better if you use a sigmoid. APR pala is for an APR, then better use a sigmoid loop para mas less ting gagawin mo during your definitive surgery of an APR, di ba? Yun yung end colostomy mo yung sigmoid loop eh. Kasi if you use a transverse loop, then what will you do ngayon dun sa distal portion nung transverse loop mo up to the sigmoid colon? Will you just remove it during your APR? Or will you do anastomosis and an end colostomy? So mas dilemma pa yun. So mas mabilis na you address your diversion according to your definitive plan in the future. Okay.
Thank you, sir. Last question, a 65-year-old female with intermittent left lower quadrant pain, no weight loss, no hematochezia, vital signs were stable. On DRE, there's empty rectal vault, no mass nor lesion noted, no blood per examining finger. What is the best diagnostic exam that you will request? Most of them, sir, answered B, CT scan of the whole abdomen.
Okay, I agree a CT scan because I think this case I think is more pertaining to a diverticulitis. Although tama rin yung you have to think of malignancy because of the age, but since there is no weight loss, walang hematochezia, then I think a best modality for now is CT scan to rule out divertic. And sa CT scan din, you can actually see some form of mass if there's malignancy. And afterwards, and then if you're sure it's a divertic, you wait for it to resolve and send the patient for a scope 4 to 6 weeks after the resolving of the diverticulitis. Okay.
Okay, sir. So, itong 30 plus participants na ito, nagkakopyahan ba kayo? Okay, pinagkakopyahan? Sige, sir. Okay, that's it for colorectal surgery.